Started.
At the short side, yeah.
Shana Patel is our second-year fellow who's been working with Dan Petroni over at Northwest Asthma and taken a unique interest in food allergy. And so she's going to give us a talk on, as you can see, immunotherapy of food allergy.
All right, good morning, everyone. Thanks, Len, for the introduction. Okay, so these are my disclosures. I've been a sub-I, but haven't received any financial compensation. Today, we're going to talk about a lot of things. I got a little ambitious on all of the trials I wanted to cover, so we'll see how much we get through. But we're going to talk about, why you might want to do immunotherapy for food, what modalities you have, how to think through each of them, and what you might have in the future, as well as how to manage kind of the bumps along the road when you're using this therapy. So just to start as an overview, as we all know, there's a lot of food allergy out there. It affects about 5 to 10% of the population that we see in the US and in developed nations, and a little bit higher prevalence in pediatric patients who sometimes will outgrow their allergies naturally. They can be life-threatening, and that's the thing that we are always cautioning people about. And our main management at this point is to avoid that food and then to manage those reactions by having injectable epinephrine available and other medications perhaps, as well as an emergency plan. But families and patients can often be extremely distressed by the possibility of having an allergic reaction to their food allergen or allergens, and this can have significant impacts on their quality of life, be socially limiting as they try to navigate events that may have their food allergens present. And so allergen immunotherapy might be something we can offer patients in the future, or perhaps even in the present, to increase their tolerance to their food allergen and perhaps bring down that level of anxiety due to bringing down the risk of a life-threatening reaction. So of course, talking about prevention, not treatment, we've learned from the LEAP study that early introduction was protective against development of peanut allergy in a group that was eating peanut regularly, 2 grams 3 times a week until the age of 5 versus those who avoided it completely. And I think of particular interest is the group that already had some evidence of sensitization. Again, all of these were tolerant of peanut at the time that they started this therapy. This is about prevention, but there were some that already had some mildly positive skin testing. And they did seem to be a higher risk group because a lot more of them compared to the skin test negative did develop peanut allergy, but it still was protective to have peanut around. And then in the LEAP on study, we saw some of that, even if you avoided peanut from age 5 to age 6, that there was still some protection that having that peanut around in early in life was protective. So that gives us some sense that having the presence of the food allergen does have an immunomodulatory effect. And so we can build on that to build an idea for food immunotherapy. So why would you want to do that? Well, our current standard of care is not all that effective, especially in preschool, toddler age groups. People are in daycare, crumbs of things get dropped and accidents happen. And so it's very, very common for accidental ingestions to happen in that age group, but even in other age groups. Fatal anaphylaxis to food, thankfully, is very rare, but it does occur, and it tends to occur in adolescents and young adults. And so that's an age group that you want to be more careful of, because they're often otherwise quite healthy and just have this condition that puts them at risk of death. The food allergy diagnosis, again, also has all of those impacts that we were discussing earlier, with the practical burden of needing to plan around alternative foods, especially for some foods that are very, very common in the diet culturally and in the household. The anxiety level that a patient has is also a significant thing to consider. Some people are very limited by their fears of the food allergy, perhaps sometimes out of proportion to the actual risk of having a fatal reaction. but giving them that sense of control that this is something active they can do to bring down that risk level can be very helpful. Let's establish kind of what we're talking about, and knowing that a lot of these terms are still in flux and things can still be a little bit loosey-goosey, but tolerance we know pretty clearly that is you see the antigen and you don't have any reaction to it. A reactivity threshold, this is what we test in initiating these trials, as well as in clinically when we're doing food challenges in the office to see, you know, how much food it takes for somebody to have a reaction if they're going to have one, if they're not tolerant. Desensitization is temporary induction of tolerance, which is largely what we're going to be talking about when we're talking about food immunotherapy. And there can be some partial protection or complete desensitization. But it requires that the food is eaten on a regular basis. And if you stop eating that food, you lose the tolerance. Versus sustained unresponsiveness, which is you know, what we might see in, say, our milk or egg allergic patients a lot of the time, where they over time become tolerant to a food that they previously reacted to, even if it's not regularly consumed in their diet. And so I think these are the concepts that we need to keep in mind when we're talking about different outcomes for food immunotherapy and different goals that we can achieve now and potentially in the future. There are different modalities available for immunotherapy to foods. We're going to talk about oral immunotherapy the most because that has the most data for it. Epicutaneous and sublingual are also under investigation in a lot of places with some data so far, but subcutaneous, I think, has enough data to show that it's generally not safe and it's not very much pursued, but we'll talk a little bit about some trials that are being investigated to potentially bring this modality around.
Why is that? Why did you cross out CITs?
It seems that just the risk of injecting the food has such a high risk of systemic reaction.
Why mechanistically is it a failure?
It's not a failure, it's just not a practical modality if you're having such a high risk of severe systemic reactions. But I will talk in the end about some work that's being done to bring that risk down. So mechanistically,
is it's so effective in inhalant immunotherapy. Do we have an explanation why it's different for food?
It's not that it's not an effective method of inducing desensitization. It's that when you're looking at the risk benefit for, is this a practical thing to offer my patient? The risk of severe reaction is so high that it's not practical to offer that at this point. But again, we'll talk a little bit about how that might change in the future. So for allergen immunotherapy to food, and this is coming from the Canadian guidelines on this, which we'll discuss more in a little bit, but this is specifically about oral immunotherapy, but conceptually generally applies to food immunotherapy. We know that a patient has some level of reactivity, which is indicated here with this dotted red line, and it's pretty low at baseline in an allergic patient. You start the immunotherapy, start an initial office visit where you try to find a dose that's below that threshold, and then you gradually increase the dose to gradually increase tolerance. As long as you keep the food in the diet, you have tolerance. There are different things that might change your threshold when you get an illness or when you've exercised, when you've taken an NSAID, for example. But usually you're pretty protected. Sometimes your tolerance level goes down and you've eaten too much of the food. And then what we're really hoping that we can achieve in the future, but aren't quite sure about yet, is that potentially you can stop the therapy or the food exposure and still maintain a higher threshold than you did before therapy. So that's the kind of what you're trying to achieve at an immunologic level. Again, desensitization, we're all very familiar with that. If you start to suppress the specific IgE expression by chronic presence of the antigen, you can be tolerant without reaction when the antigen is present. But if you lose that antigen exposure, the IgE is going to build back up. Whereas with sustained unresponsiveness, you have long-term changes in food allergy, in particular the interest as you might expect, is in decreased production of that specific IgE and increased IgG4 production. There is a lot of work being done on what those immunologic changes are, but that's all I'm going to say about it for today. So now that you have a sense of why you might want to do this therapy and what you're aiming for, you might wonder what the guidelines say. And for us, we have the food allergy practice parameter that has not been updated since 2014 in the pre-LEAP era. And it pretty just clearly says that we don't have good data to say that the benefits outweigh the risk, or sorry, yeah, the benefits outweigh the risk, which is fair enough in 2014. I was mentioned that sublingual immunotherapy is one modality you might consider, but in the 2017 sublingual immunotherapy practice parameters, they're pretty clear that they're only talking about use for allergen immunotherapy for allergic rhinoconjunctivitis, and specifically not for other conditions such as food allergy. The Europeans have had a guideline on allergen immunotherapy for food that they put out in 2018, which is something that we in the US might rely on for some guidance. And in their practice guideline, they recommend, based on the data, that it seems worthwhile to do immunotherapy for peanut and cow's milk allergy. You can consider it for hen's egg allergy. They don't think it's worthwhile to do for adults, and they're only convinced about desensitization, not sustained unresponsiveness. That sublingual immunotherapy has fewer systemic side effects, but OIT has seemed more effective, and that for subcutaneous, the severe adverse reactions make it not a viable modality, and for epicutaneous, at that point, they just didn't have enough data. The Canadian guidelines came out in 2020, and they, again, recommend it pretty strongly for toddlers, preschoolers, school-age children, adolescents, say have some opening that adults might benefit. They, again, recommend desensitization as your goal for this therapy, not sustained unresponsiveness. They are a little bit broader. They say any food that somebody is allergic to may be a candidate for food immunotherapy. And they specifically address the question about baked, egged, and milk therapy versus specifically doing oral immunotherapy to an unbaked form of egg or milk, and say that there is evidence that the oral immunotherapy approach is more effective at inducing desensitization and sustained unresponsiveness. The sublingual immunotherapy, again, less effective than OIT, and epicutaneous, again, not enough data. The United States still is working on catching up, but that we have had the Food Allergy Research and Education Consensus Report in 2019 recommend that oral immunotherapy start being considered in a shared decision-making process with appropriate patients, but that we still have a lot of data that we need to be able to bring this therapy forward in a broad sense. So that's the kind of recommendation level. Now at a clinical level, how do you assimilate this and put it into practice? First, thinking about what foods you might want to offer this treatment with. Again, to summarize, in the United States, there's only, as we all know, one FDA-approved product for oral immunotherapy that was approved in early 2020, which is a peanut allergen powder. The European guidelines, again, said peanut, milk, and egg are good candidates. Not a lot of data about other foods, whereas Canada says any food allergen is fair game, but specifically notes that you might want to think about the burden of egg and milk allergy if it is persistent. So you might want to think through kind of what is most common, what is an important food for that patient, or a high risk exposure for their particular set of household and cultural habits, and the environment around them, how likely they are to encounter that food. And you might also think about the natural history of that food, how likely they are to have persistent disease into adulthood, where you might think through some of the allergens that they have a high likelihood to outgrow, and some like peanut and tree nuts that may be more persistent, as well as, again, with shared decision-making with the family, how comfortable they are with those risks. The,
We know, you would think the answer is in the natural history here, immunologically, why milk, egg, wheat, and soy resolve, you would think would not be good candidates for all this effort, and why tree nuts and peanuts so much less. Anybody studied the immunologic differences? Because you would think the answer is why you become naturally tolerant to some of these.
yeah, I think that is an area of a lot of interest. I can't say that I know the answer. I'm sure that some of the future studies or studies that are ongoing about like epitope matching and our understanding of what some allergens are a lot more persistent than others will be enlightening. But I would say, I think balancing that, yeah, egg and milk allergy are very likely to be outgrown, but for that 20% that remain allergic into adulthood, that's pretty limiting to their life. And so if we could potentially increase the likelihood that they will outgrow it, that might be worthwhile to consider.
When you were preparing this talk, do you have any idea how widely used the peanut product has become in the US?
I haven't looked into that. I've kind of more looked at the data on the effectiveness and safety of these therapies and not so much on what's being done in the US. I tried to look for some survey data on what people are doing in practice, but in my brief search, I wasn't able to find anything. Okay, another thing that you might want to consider when you're thinking about a food to potentially desensitize somebody to is the likelihood of having a fatal reaction. So this is an analysis of the data across a few different countries. The one thing to note, this was very uncommon and to have food-induced fatal anaphylaxis, but in those that it happened to, they tended to be quite young. The food triggers most commonly were peanuts and tree nuts. So that is something to think about when you're thinking about how likely somebody is to have a fatal reaction. Cow's milk was also a very common cause, or sheep and goat's milk, depending on the region that you're in, which I'm sure is about what is commonly used there. And then similarly, seafood was also a very common cause of fatal reactions, and much more so in Australia, which I think again goes to the point of what is common for a particular patient in their culture and household. A lot of these patients had had a history of food allergies. Some of them had had anaphylaxis in the past, but quite a few of them did not have an injectable epinephrine. But even in some patients who did get epinephrine on time, they still had fatal reactions. So that goes to show the unpredictable nature of this and what we're always trying to prevent. So other things to think about beyond, the food allergy that they're allergic to specifically, you of course want to make sure that they have an IgE mediated reaction to food, because this therapy doesn't make a ton of sense otherwise. You might consider their individual risk factors, again, their food allergy, and then as well as their tolerance for the therapy. And we'll talk a lot more about the side effects of each modality in a little bit, but kind of their baseline skin, GI, respiratory symptoms are of particular importance, as well as their just general health. And then you especially will talk, a lot of this work is being done in pediatric patients. And so getting an understanding of the patient and their family is really important. You need a family that understands your counseling, that understands the risks and benefits, that understands the goal of desensitization, that understands how to manage reactions safely at home, since they can be very common, and to whom that kind of all of those burdens of therapy are worth that sense of increased desensitization and protection that this may offer. And so you should have informed consent as part of your process. And then the pediatric patient, particularly for oral immunotherapy, but for all of these, has to be able to participate. They're the one that's going to be eating the food every day. So as developmentally appropriate, you should also make sure that they understand why they're doing what they're doing, and make sure that they have buy-in as well. And then again, very clearly communicate the goals of therapy. You may be particularly eager to treat patients with history of severe anaphylaxis, but particularly for oral immunotherapy, that might make the therapy a bit more high risk for them as well. You want to make sure that other disease, skin disease, asthma is well controlled. You may not want to start this immune modulating therapy in somebody that has other systemic disease concerns or is at higher risk of having severe anaphylaxis. And then again, from social concerns, taste aversion can be a big barrier, which you can try to work through by mixing with different things. But for oral immunotherapy, the child has to eat the food. So that can be a barrier if they really won't do that. And then you need a family that's going to make sure to do this every day, because for desensitization, you don't want to lose that protection and then have the risk of having a reaction if they've missed a few days, but also a family that will recognize and understand your counseling on management of reactions and on when to reach out for guidance. And then we'll talk a little bit about the process of oral immunotherapy, but the ability to manage reactions when you're updosing oral immunotherapy in the office. And again, that patient and family education is very important. So now we can talk a little bit more about the modality, starting with oral immunotherapy, which we'll spend the most time on because there is the most data for it. So again, the concept, you're starting a daily food to desensitize them, starting below their reactivity threshold and then gradually updosing them over time. Currently in the US, there's only one FDA approved product for peanut immunotherapy. You don't have an FDA approved product available for other foods, but you can consider off-label using measured amounts of other foods such as nut butters, yogurts, potentially baked products as well. The flours, these things can be mixed into pudding or applesauce or other vehicles. And you need to be able to make sure that you can measure a consistent amount of that food and that it's practical for the family to be using that daily. The peanut product is a 300 milligram daily maintenance dose. We'll talk about the trials in a little bit of detail, but there can be different regimens with different dosing schedules, but you're typically updosing every 2 weeks or so, depending on how the patient is doing with the dosing or side effects. You may alter this schedule. And for oral immunotherapy, you'd be doing those dose escalations in the office to make sure that they tolerate it. Once they're at maintenance, you might space out your visits a little bit, and then maintenance is currently thought to be indefinite because we don't have a lot of data on the long-term sustainment and responsiveness at this point. On the left is some things to think about for the home dosing. And again, it can be quite a lot for the family to navigate. So it needs to be the right family that can incorporate this into their life. So things like limitations such as taking the dose with the meal, being able to absorb them for at least 1 to 2 hours after a dose. So shouldn't be something that they get right at bedtime, and then avoiding exercise and heat exposure right before and 3 hours after a dose. So things like sports or other activities, bath time, dinner time, meal times, you have to think around all of this, as well as other things that come up all the time, taking an NSAID for a sprain or a virus, having a viral illness, that kind of thing.
Does the peanut product have all those warnings in its product label?
Yeah, I think that there's a lot of patient information and provider information that comes with prescribing it to cover things. Okay, so going into the FDA approved product here, this was the trial that was published in 2018 that led to its approval. So this took patients age 4 to 55 years with peanut allergy, defined by reactivity on enrollment to 100 milligrams or less of peanut protein. They were randomized to a maintenance dose of 300 milligrams peanut protein or placebo for 24 weeks, and were then given a challenge of tolerating a single dose of 600 milligrams, which by their graded challenge was a cumulative dose of about 1,000 milligrams of peanut at the end of that 24 weeks with either the peanut protein product AR101 or placebo. First, just talking about a lot of the adverse effects that patients have had, which we'll look at through the trial data a little bit more. But GI symptoms are very common. EOE seems to be about 2 to 5% of patients may develop it, though a lot of patients will have symptoms and weren't always scoped in these trials to confirm whether they had EOE. Flares of skin symptoms can occur. Respiratory is usually rhinitis, but they can have wheezing, dyspnea that's typically responsive to therapies, and they can have systemic reactions. And then you can modify these things based on how they're doing. There's a lot of leeway that you have to change or modify their dose. In the Palisade trial, the patients that were treated with the peanut immunotherapy tended to, it seems, drop out of therapy at a higher rate than the placebo. So that's one thing to keep in mind. But of those that managed to continue with therapy and reach the exit challenge, of the 4 to 17-year-old group, which was their primary consideration, we did see quite a big difference, 63.2% in the rate of tolerance to that exit dose, which was cumulatively about 1,000 milligrams of peanut, around 3 peanuts or so. The 18 to 55-year-old group had no significant difference. So that is, again, suggestive of the idea that there may be a window of optimal therapy, and we'll talk a lot more about that as we build through some of these trials. The
just didn't hold up statistically.
Yeah, so I think that depending on the trial, how it was done, how long therapy was for, this was a relatively short amount of therapy, 24 weeks. Some of the trials we'll talk about have gone up to a year, 2 years, 2.5 years of therapy. And I think that there may be differences in what you see as well. And then some patients were even able to tolerate quite a bit more peanut as well. So I think going into that idea of efficacy across age groups, in the 18 to 55-year-old group, there was not a statistically significant difference. If you subdivided the pediatric patients into 4 to 11 and 12 to 17, you did see that while, like, on average, the between group difference between peanut immunotherapy and placebo was 63.2%. It was a little bit higher in the 4 to 11 age range and a little bit lower in the adolescent group. And then again, looking at efficacy, so the range of symptoms that they experienced at the exit food challenge, the treatment group was a lot more likely to have absolutely no symptoms, and the symptoms that they may have had were much more mild than in the placebo group, and they became much less likely to require epinephrine at the exit challenge, though some of them still did. So looking at adverse events, the first thing is that this was very common both in the treatment group and in the placebo group. Quite a lot of the adverse events were in the GI realm, with abdominal pain, vomiting. This was much more common in the increasing dose phase than in the maintenance phase, but some people still had persistent symptoms chronically into the maintenance phase. The risk of systemic reactions was more common in the treatment group than in the placebo group, and it seemed to be pretty consistent across both the up dosing phase and the maintenance phase. So that's something to consider. But when you look at severe reactions and severe systemic reactions, overall the risk was relatively low. So that is the trial that led to approval of that product for peanut immunotherapy by the FDA. There have been a lot of oral immunotherapy trials. So how do we assess all of them? We use meta-analyses, and we're going to talk through 2 of them. This is the first one that we'll talk through that came out in 2019, and then an updated one that came out last year. So in this meta-analysis concluded that yes, OIT is effective in achieving desensitization, but that people treated with OIT have higher risk of anaphylaxis. That, as we saw in the Palisade study, occurs both during buildup and maintenance phase, that these people were using epinephrine more often and having anaphylaxis more often. And so if your whole goal is to prevent systemic reactions by desensitizing them, and you're instead having situations where you're using epinephrine a lot more often, is that really worth it? That was the conclusion of that meta-analysis. Yeah.
These studies not include the people with the most serious reactions in the first place? Do they exclude people who have life-threatening reactions?
Yeah, all the trials have their own inclusion-exclusion criteria, but usually people that had cardiorespiratory compromise are excluded from the trials.
Does anybody in this room use the product? I've never used it. Have you used health?
Twice, and both of them ended up in here.
They both ended up in the emergency room.
It's the same thing she just said. People who do it end up using more epinephrine than people who tell this stuff. My limited experience of two was not great.
There's a few drink fellowships and not here specifically with Palforzia and overall with Palforzia, the maintenance still doesn't be
so this updated trial in 2022. So now, a lot more trials have published results between 2019 and 2022. This has been a hot area of research. So again, these are primarily pediatric patients that are included in these trials. But it again shows that desensitization is pretty darn successful. And of particular interest, the ability to tolerate 300 milligrams and the ability to tolerate 1,000 milligrams, so about 1 in 3 peanuts respectively, is pretty darn good. And the number needed to treat is pretty low to get this level of desensitization. We don't have enough data for sustained unresponsiveness, and only one trial that was included in this meta-analysis really reported that as an outcome. This meta-analysis said that adverse reactions and severe adverse reactions were really common in both placebo and control groups across the meta-analysis, and that there wasn't a statistically higher signal for adverse reactions in the treatment group, is particularly for severe and life-threatening reactions. So it is hard to know how it's going to bear out as we continue to evaluate and reevaluate the data as things come forward. But it seems like in the realm of having food allergy, the risk of having these reactions exists both with and without therapy. And it's something to discuss with families that they may be very likely to use epinephrine while they're on this treatment. But for some families, having that sense of control that they know that they're giving that treatment and they can monitor for that reaction versus the unknown of what might happen in the classroom when they take a bite of something on accident can be worthwhile. And for some people, it's not worthwhile.
I'm sorry, is this saying that people in control groups not being given peanut had systemic reactions equal to those in the challenge group?
Yeah, that overall, as you can see, kind of for all of these, that it crosses the line. So there was nothing that had a consistent across them, all of the trials. Some trials individually would conclude having more systemic reactions in the treatment group. And again, this is not necessarily right after taking a dose. It's kind of during that period of time that they're in the trial, everything gets reported. So there can be all sorts of reasons that people have systemic reactions to things across the time span of a clinical trial.
So it wasn't necessarily due to peanut.
Not necessarily. And I didn't dive in a ton of detail to dissect all of that.
It doesn't make a lot of intuitive sense that the control group should have equal systemic reactions.
Well, I think that there's potentially different reasons that somebody could be having systemic reactions. And again, I didn't dive into the details of what's been reported to say this with confidence, but potentially accidental exposures in the control groups can be pretty common, again, as we talked about at the top, versus having reactions to the therapy may be more common in the therapy groups. So this meta-analysis also specifically talked, so that was all relative to peanut immunotherapy. It also specifically commented on trials for OIT to cow's milk and to hen egg, and did find effective desensitization. And then again, that adverse reactions are common and GI symptoms tend to be the most common, but that severe reactions were rare. and then did not have enough data to comment on quality of life impacts or other foods. And so then to talk briefly about milk and hen's egg, I just show here one trial that compared baked egg to oral immunotherapy to unbaked egg, and this trial did report more sustained unresponsiveness. And I'm sorry, I don't recall exactly how that was defined in this trial with the oral immunotherapy. And then there's a lot of work that has been done on other foods that I'm not going to get into a ton today. So I want to kind of talk a little bit more about some of more recent trials, getting into the idea that there may be differences depending on the dose of your maintenance, the duration of your maintenance dose, and then the age group that you're treating with the oral immunotherapy. So remember, for the AR101 product, the maintenance dose was 300 milligrams. In this POISE trial, the maintenance dose was a whopping 4,000 milligrams. And then instead of 24 weeks, these are 104 weeks, so 2 years. And then this trial is trying to start also getting at the question of sustained unresponsiveness. So they had, in addition to the placebo group, a treatment group that went on to then take a smaller dose, 300 milligrams for a year versus no peanut at all for 1 year. And then looking at both their desensitization right around the end of 2 years of therapy, and then potentially signs of sustained unresponsiveness. And so looking through this, first at the top, it's comparing the group that did oral immunotherapy for 2 years and then stopped for a year versus the placebo group. Did see quite a bit of desensitization in the peanut group versus the placebo group. And then interestingly, at week 156, so a year after discontinuing therapy, about 13% of the group who had previously gotten oral immunotherapy were still tolerant to the exit dose versus only about half of the placebo group. The peanut group that then stopped the immunotherapy versus the ones that maintained a small dose of oral immunotherapy for the next year, they had similar rates of desensitization at 1 year. But at week 156, again, the group that maintained some peanut did have higher rates of maintaining tolerance to peanut or tolerating that challenge at week 156. So that suggests that having some ongoing exposure, even if it's a smaller dose than the maintenance dose previously, can still be protective if you did enough time at the higher doses, potentially. So it'll be interesting to see how this bears out in the future. And then trying to get into the age group a little bit, I'm going to end our discussions of oral immunotherapy with the IMPACT trial. This one came out just last year in 2022. So this took a lot younger patients than in many of the trials we've discussed previously, patients aged 12 to 48 months, so 1 to 4 years, that were quite sensitive to peanut. I think they took reactivity less than, I want to say 500, but the median reactivity dose was 25 milligrams, and they built them up to a maintenance dose of 2,000. So again, quite a bit more than the 300 in the currently approved product. And then they treated them for 134 weeks, which is about a little over 2.5 years. And then again, trying to get at the idea of sustained unresponsiveness, they then had 6 weeks of avoidance to therapy, and looking at their tolerance of a cumulative dose of 5,000 milligrams of peanut protein. They found quite a bit of desensitization in the treatment group. Sorry, this is supposed to say OIT versus the placebo group, as you might expect based on all of the trials we've seen so far. But then more interestingly, 6 months later, there was still about a fifth of the treatment group was able to still tolerate that 5,000 milligrams of peanut protein. And then they subdivided this by age group. So it seemed, again, particularly if you started less than 2 years of age, quite a lot more of them maintained that tolerance later on than in the older age groups. So even the 3 to 4 age group. So that, again, I think brings back the idea that there is this window of immune modulation that you might be able to have a bigger impact with, I guess that's the way let's try to call it that, with the disease, or sorry, with the treatment. So yeah, results by age here again. And then again, safety, the reactions were really common in both the oral immunotherapy and the placebo groups. They were most frequently mild to moderate GI, skin, respiratory symptoms, things like abdominal pain, diarrhea, eczema flares, rhinitis. And then they were most frequently in the buildup phase. But there were some immunotherapy patients who did require epinephrine. That was quite common. And there were some patients who were not able to continue the therapy, or due to having that systemic reaction requiring epinephrine, decided to withdraw from the therapy. Okay, so that's everything that we're going to talk about for oral immunotherapy. And then we're going to just spend a little bit of our remaining time on a couple of the other modalities. So epicutaneous immunotherapy, some things that you might want to consider why you would use a patch with a food allergen on it instead of an oral therapy when you're trying to protect against an oral exposure. The pros, your ease of dosing can be quite a bit more flexible. You don't have to time your dose based or adjust it based on illness, on physical activity or exercise. You start with these dose and you continue it. So there's not those clinic visits frequently for updosing at the start of therapy, which can be quite burdensome for some families. And there's quite a few systemic side effects, but as we'll talk about currently, the data suggests that it's less effective than oral immunotherapy. Of the side effects people have, they tend to be local skin reactions that are pretty treatable, but it is not commercially available at this time. So going to the PEPITES trial published in 2019, these were pediatric patients aged 4 to 11 who were peanut allergic, and they were treated with the patch that had 250 micrograms, so much less than the oral doses, or placebo for 1 year. They set a definition of responders based on the initial food challenge at enrollment. And so if they were reactive to less than or equal to 10 milligrams, a success or response to therapy was considered an exit food challenge where they tolerated at least 300 milligrams. And if they were reactive between 10 and 300, then they had to tolerate at least 1,000 at the exit to be considered a success. They used these patches again, and they had a system for rotating them daily on the back in through different sites. The updosing period was based on the length of time that the patch was worn, starting with 6 hours a day for a week, then 12 hours a day, and then maintenance was considered 24-hour wear, and they allowed some leeway of about 4 hours. So in the patients who were treated with the epicutaneous immunotherapy, about 35% of them met their responder threshold based on their initial reactivity threshold versus 13% of the placebo, which was a difference of 21.7%, which did have a low p-value, but they had previously specified that their confidence interval would have to, the lower limit would have to be at least 15% for this to be considered a significant clinical difference. And so it did not meet that threshold, and this was considered to be a negative trial. There was a good signal for safety. While adverse events were common in both the peanut patch and the placebo patch groups, they tended to be local administration site reactions, which were typically pretty easy to treat. They tended to get better over time, but some people did have chronic symptoms. For respiratory symptoms, these were quite rare. For systemic reactions, these were quite rare, and there were no significant GI symptoms reported. Going back to that meta-analysis we talked about for oral immunotherapy, for epicutaneous, it again says that there's primarily pediatric patients in the trials, that it is effective at inducing desensitization, but that it is a much smaller rate compared to oral immunotherapy. And if we compare here, their reported rates of tolerating 300 milligrams, about 1 peanut's worth, 18% in the epicutaneous immunotherapy trials versus around 63% in the oral immunotherapy.
My understanding is that the original patches didn't adhere very well. You studied with that patch and newer ones are better.
Yeah, we're going to talk about kind of future directions and at the end. But going on what's been published so far, or at least as of this meta-analysis, that was the data in the trials around then. The adverse reactions were rare, but they were usually cutaneous reactions at the patch site. Very briefly, we'll talk a little bit about sublingual immunotherapy. Here is one trial that was treating just a cohort study, so there was no control group, treating with 2 milligrams of peanut protein sublingually. So again, much lower than the doses used for oral immunotherapy. And then seeing their ability to tolerate 5,000 milligrams. They set quite a high bar for the exit challenge. And they did see some rates of desensitization. And it seems that mostly people had local symptoms such as oral pruritus, and in their cohort study across the 3 to 5 years, no epinephrine was needed. The meta-analysis currently just says that there is some signal for desensitization, but they only included one study in this meta-analysis, and so overall their confidence is very low. And then again, the rate of reported ability to tolerate 300 milligrams is quite a bit lower than the other modalities. So just to summarize kind of what we know so far, it seems like oral immunotherapy, you can get to pretty large maintenance dosing depending on the particular clinical trial regimen. Quite a range was used. That they show pretty successful desensitization and more effective than the other modalities. Currently, the only FDA approved product is for peanut oral immunotherapy. And it may be a stronger benefit if you start in younger patients, and if you consider the foods that may be particularly of interest. But it is very labor and time intensive. You have all of those office visits during the updosing. You have all of the reactions and managing them and adjusting doses along the way. And people will very often have systemic reactions or develop side effects that lead them to discontinue therapy. Epicutaneous immunotherapy seems to take a lot of that burden out of the picture, but it seems to not be as effective as oral immunotherapy from what we know so far. And then for sublingual immunotherapy, again, seems to be quite a bit safer and easier with mostly local symptoms, but not as effective as the other modalities. We're talking a little bit about what is being studied for the future. First, can we ameliorate a lot of those very common side effects with use of something like anti-IgE therapy? And then in particular, I haven't talked a lot about this, but ability to tolerate multi-food oral immunotherapy for patients who are allergic to multiple foods. And so there's a lot of promising work in that landscape. For epicutaneous immunotherapy, there is the EPITOPE study that we will be seeing coming out in the future that is following up from PEPITES, having the same dose of peanut immunotherapy, but a modified patch shape and adhesion properties, which they're interested to see if that changes the efficacy signal that comes out of that trial. And then, as we discussed earlier, currently it seems that subcutaneous immunotherapy leads to too many systemic reaction, but there are some therapies on modified protein allergoids or allergenoids that may be able to modulate the immune system to develop tolerance without being so immunogenic to cause as many systemic reactions. So it'll be interesting to see how that work bears out. And then there is some work on seeing whether there's impacts between the microbiome and development of tolerance. So this is a trial that looked at OIT alone versus placebo, and then probiotic plus OIT. And one measure that they were looking at was sustained unresponsiveness, and they didn't find any difference in their rate of achieving their primary outcome, but they do report that the probiotic group may have had decreased GI side effects. That's something to think about as you're managing side effects in patients. And then, of course, our white whale is sustained unresponsiveness. And I think one thing we suffer for in our study so far is having a consistent definition of what that is. A lot of trials have had different lengths of therapy and different lengths of time off of therapy before they measure sustained unresponsiveness. And then again, different dosing for their food challenges. So we need, I think, a consistent definition of what that really is and what that means. But there is some promising data that we might be able to achieve this in some patients, and particularly if we get them at that right in the right time frame. So that's everything I have for you. These are my references, and the word of the day is muscle. And happy to take any questions. Okay. Yeah.
Sort of a two-pronged question. One is, if you look at people who have desensitized themselves, what I notice is there's a lot of clinical data, but there's no immunologic data studies. So do they make more protective antibody? Did it turn off production of allergic antibody? Do we understand the mechanism of any of this at all, other than just it works or it doesn't work? And I guess that's where I'm confused, because if you look at the people that you did your studies and just say 20% of people can be desensitized over time, and in that one study, if you went 4 years off therapy, it was 20%. So it looks like it's exactly the same as the controls.
Yeah, I think that for some of these foods, there was like the, trialing baked milk versus baked egg, getting at your second question first. So suggesting that the oral immunotherapy did outpace the natural history. So I think there could be some immune modulation there that may be still happening. A lot of the trials collected data on things like IgE levels, specific IgE levels and IgG4 levels. But I think that right now there's not a lot that is known about what leads to successful immunotherapy, what you might be able to measure at baseline that might predict their likelihood of outgrowing something naturally versus not. We're just really, I think, at a stage where a lot of work is being done to look into those questions, but not a lot of answers have come out yet. Okay, sorry. So the questions were kind of like what, for the people that are online, what is known about immunologic data? How can we compare immunologic changes in patients who naturally outgrow their allergy versus patients who are treated with immunotherapy? And then there is a comment that that from Gideon Lack's data from following up from the LEAP trial, that the specific IgG4 and IgE levels seem to follow patterns that mimic the patterns you see in immunologic changes to venom immunotherapy. Thank you for that. Yeah, Gabe.
Yeah, for epicutaneous immunotherapy, I guess with patients with eczema, I guess my understanding is we think that patients can get sensitized, especially patients with eczema, when they have cutaneous exposure. So I guess, are those patients excluded in that? I'm just thinking about generally, my understanding is that if you have oral ingestion that prompts, desensitization or creates tolerance, early exposure, but if you have early exposure to cutaneous, allergen, someone has eczema.
Yeah. So the question is kind of, thinking about epicutaneous route of administration and our thoughts that potentially skin exposure in patients with eczema, for example, that have disrupted skin barriers is a risk factor for developing food allergy. How can you think about how epicutaneous immunotherapy is working in those patients and whether they're at risk of having worse allergy? So I think first, the kind of coexistence of eczema and food allergy is really common. So there's no way that they would have been able to exclude those patients from the trial. So there are rules about where you can put a patch and what the baseline skin is. So they want you to be putting it on healthy skin and not inflamed skin. I didn't include this, but they do have kind of proposed mechanisms for having that very low dose of food exposure and how that might, present to antigen presenting cells, leading to kind of stimulation of tolerance immune mechanisms. But again, I think that's pretty early work, so we can't draw a lot of conclusions on how it's differing from desensitization kind of skin exposure. But very interesting questions. And then, would from the chat, would epicutaneous immunotherapy have greater likelihood of local reactions due to them having higher likelihood of eczema? So those local reactions are super common, and that is usually managed just the way that you would manage their eczema with topical corticosteroids. They do rotate through in the trials 6 patch sites. So and changing the patch every 24 hours. So an area that gets irritated does have a break of about 5 days or so before it's seeing the patch again. That is some time for those topical corticosteroids if the patient is needing them to do their magic. But that is a very common thing to be managing. But I think the nice thing is that you're not, at least it seems from the trial so far, not managing a lot of those chronic GI symptoms that the oral immunotherapy patients experience.
Is there any data yet? My takeaway from this is if we could make epicutaneous work, it's clearly the favorable way to go. Is there any data with a newer patch yet that it's more effective?
Yeah, I don't think that there is anything that's come out from those trials yet, but it will be very interesting to see what is published.
Just wanted to add a few biomarkers in terms of knowing baseline, how to predict who would be a better sustained desensitizer versus responsive patient. We don't really know that right now. That's certainly something that we have a high need to figure out. Don't exclude any patient based on whether they've had a more serious anaphylactic reaction versus a mild reaction at baseline, or to exclude based on testing. But we do see that in patients with higher baseline RH2, the likelihood of having reaction is higher. And I think, I don't know, part of this is more psychological or not, starting these kids later on in life. Probably a multitude of that. And in terms of markers, we are measuring skin prick testing and IgE levels. We actually see things increase after reaching maintenance for at least around 6 months. And standard for these patients is that we retest roughly every 6 months anyway. So we could actually see an initial increase in IgE prior to taking down about that point. So that's also something to think about. Still not discouraged at the 6 month after. Why are my allergies?
The same thing happens with inhalant immunotherapy. You put people on immunotherapy, right? Usually it goes up.
Okay, any other
Thank you
questions?
for,
All right, thank you, everyone.